Live and Learn. Today we're going to be talking about myocardial infarction. Figured with Valentine's Day being yesterday, why not talk about the heart today and all the things that could go wrong, right? So let's just hop right in here. My name is Caitlin. I am a critical care nurse. That's my background, and here now I work at UWorld. But go ahead and drop in the chat here, like what semester you're in of nursing school, what school you go to. Let's kind of get that conversation going. And we're going to go ahead and look at our question for today. So our question says here, the nurse has attended a staff education program about myocardial infarction, or MI. Which of the following statements by the nurse would indicate a correct understanding of the program? Select all that apply. So when we have a question that says select all that apply, we are going to have multiple correct answers here, okay? And when we're asked about a correct understanding of a program, that means our answers that are true statements are going to be correct answers, right? Okay, so let's dive in and look at them. Option 1 says MI is diagnosed with a nuclear stress test. Option 2 says nausea and vomiting may be symptoms of MI. Option 3 says aspirin should be administered to clients experiencing MI. Option 4 says diabetes mellitus increases the client's risk for ST segment elevation MI, or STEMI. And then option 5 says MI is caused by altered, impaired electrical impulses from the SA node. So keep all that in mind, and we're gonna come back to that at the end. Let's talk about a little bit.
Let's make sure everybody's on.
Okay. Okay, so let's talk about what classes you guys are in. Kind of drop those in the chat, or your favorite part about nursing school. I'll tell you a little bit about mine while we're waiting for some comments in the chat here. My favorite part of nursing school was critical care nursing, which tracks because I did go into the ICU. It was just so much fun. I really loved just that it was kind of like a constant learning experience. Every day was a challenge, something new. So that's awesome. So keep that in mind. You know, if you're in a class and you don't love it, it doesn't have to be like the avenue you go into. There's so many avenues. You can specialize in so many areas. And that's kind of the great thing about nursing, right? There's always something to do, always a different avenue you can choose. So that's something that's been really great. Like it's no pressure, right? You go into it, and if you don't like one thing, you can switch it up and do another. So that's something that's awesome. Yeah, that's probably my biggest piece of advice, is just not to get too stuck in one area. Yeah, and we're currently working through getting everything up and running. So you know, this is a learning process as we go, right? We never stop learning, and that includes all of us here at UWorld. And that's something that's really awesome about UWorld, is that we constantly evaluate our content. We are constantly learning, getting the newest books, looking at test plans and all those things to make sure that you guys have the best content available. And it's really helpful. So that way, you know, when you're getting a UWorld question, it's not an old question. We constantly have eyes on these things. We're constantly updating, making sure it's current with practice. And then we also have really helpful feedback buttons on all of our items, which is great, because if you see something that you're like, oh, I don't know, I kind of was taught something different in nursing school, you can submit that feedback. We look at it, take it into account, and we can fix the problem and move on to make sure you're always up and relevant with everything you see. So another great thing that we love about UWorld is some of our product features that I think are just really helpful. So we have built-in note cards, which is really great. So when you're on an item, and let's say you get the item wrong, it's something you need to study a little bit more about. You can snap it, put it on a UWorld note card, and then save that and implement it back into your study plan, where later you can go through these note cards you've created, kind of rate yourself on how you're doing, and it gives you the option to just kind of get that information into your memory. So if you wanted to learn about, risk factors for MI, which we'll talk about later, you could do that on your UWorld note cards. Another great thing is we have a notebook. So let's say you're not a flashcard person, and that's okay. We also have a notebook that's really great, where you can kind of pull pieces of content and put it in your UWorld notebook. So that's something that's really great also. We have a huge variety of topics, and things to choose from. So if you need to know more about like heart failure, you can really focus your note cards on that and create different like decks of note cards, if you will, which is nice because then you don't have to take up that space in your bag, because I know the bag's heavy enough with your laptops and everything. So that's really great, and just something that I found really helpful. I actually used UWorld long ago for my own nursing exam. So that was, I just really love it. Okay, we are gonna switch gears here, go back to MI, the reason we all came here today. So we kind of looked at our question a little bit, and we're going to follow up on that question at the end. So if you had a chance to view that question, drop your answers in the chat. What do you think is right? And we're going to talk through it, and then we'll go through it all at the end, just so you have a full understanding of MI, hopefully by the time you leave today. The question, okay, let's go through the question one more time, just in case. Never hurts to look at it twice, right? We'll give you another chance to see what the answers are. So option one, or our question says here, the nurse has attended a staff education program about myocardial infarction, or MI. Which of the following statements by the nurse would indicate a correct understanding of the program? Select all that apply. So before we look at our options, let's take another peek at our actual question here. So when we have a question that says select all that apply, we are going to have multiple correct answers. So that's something really important. You can kind of get caught up if you only click one and move on. If it says select all that apply, there's going to be multiple that apply, right? And then another thing, when we're asked about like statements that indicate a correct understanding of a program, they are going to be true statements that are our correct answers. So that's something to keep in mind. So another way to look at this is when you read a statement thinking, is this true or false? If it is true, it indicates a correct understanding of the program, and that's your answer. So let's look at our options here. Option one says MI is diagnosed with a nuclear stress test. Option two says nausea and vomiting may be symptoms of MI. Option three says aspirin should be administered to clients experiencing MI. Option four, it says diabetes mellitus increases a client's risk for ST segment elevation MI or STEMI. And option 5 says MI is caused by altered impaired electrical impulses from the SA node. That one's a little bit of a mouthful, but we'll talk about it later. So kind of put in the chat here what you think the correct options are. And let's talk through MI a little bit. So MI, myocardial infarction. What happens in an MI? So we have plaque buildup that goes into the coronary arteries. Our coronary arteries slowly over time just get smaller and smaller and smaller. Think of kind of like buildup in a hose or buildup in a pipe, right? That vessel becomes smaller and smaller. Blood flow can't get through. So these plaques form. What happens is these plaques become unstable because they're not meant to be there. And when that happens, the plaque sometimes can rupture. Your body's like, hold up, this isn't right. What's going on here? So then we send platelets and all other goodies to that site and form a clot, right? We're trying to fix it, but we kind of made things worse. When that happens, we're not getting blood flow through that artery. We're not getting blood to the heart. So when that happens, we lose oxygen supply to the heart. We lose blood flow. The heart's a muscle. So we don't have enough oxygen to work. That muscle can't contract. That muscle can start to get ischemic. Like it's just bad. It's just bad all around, right? So we need to open that back up. Let's talk about risk factors a little bit. So anything that increases your risk for coronary artery disease increases your risk for MI. So coronary artery disease is essentially that plaque buildup in the heart before it is ruptured, right? So things like diabetes mellitus, hypertension, smoking is a big, big, big one. Hyperlipidemia, right? We have all those extra lipids, that extra cholesterol floating around in there. It's going to stick to the inside of our arteries, cause those plaques. Obesity, a sedentary lifestyle, a family history of MI is a big risk factor, really with any kind of heart disease. And then stress also can really can increase that risk. Additionally, like recreational substance use, like cocaine, that increases like the workload of the heart starts pumping faster. That can increase our risk for MI as well. So with coronary artery disease, right, all those risk factors are the same. To diagnose coronary artery disease, we need to look at labs, all those things, but another big piece is the nuclear stress test. So with a nuclear stress test, we inject dye as somebody is like on a treadmill or bike, or we can give them medication to kind of stimulate that like kind of exercise-induced response. But we inject the dye. Then we look under nuclear imaging, we look at the arteries, and we look at the blood flow. How's everything flowing? Are we at risk for MI? Maybe. Hopefully not, but maybe, right? So we use the nuclear stress test for that. Okay, and then let's talk about manifestations a little bit. What are we going to see? Like when these clients come into the ER or when we see them on our floors, what are these people going to look like? How should we know that they have an MI? Drop what you think is like the number one risk factor or the number one manifestation, I'm sorry, in the chat. And let's see how we're doing here. So one big thing with an MI, we're going to have chest pain typically, right? We have that chest pain, that pressure, an elephant sitting on our chest. It may radiate, may go to our neck, our jaw, down the left arm is a really common place as well. But it's going to be kind of like a crushing, debilitating type of chest pain. A lot of times also our clients will say they feel like they're about to die, right? There's that like feeling of impending doom. That's a big red flag we need to watch for. So that as well as additionally, like this chest pain within MI isn't going to be relieved with rest. So let's say we're out working, we're mowing the yard, we have chest pain, we sit down and it stops. The chest pain stops. That's not an MI. This chest pain is going to continue regardless of what we do. Again, this chest pain is going to last like, I don't know, 20, 30 minutes or longer. But we can also have atypical symptoms. So those are going to be more common in our women, our clients with diabetes, our aging population. So a lot of times with women, it can be harder to diagnose because they have like really non-specific symptoms, stuff like fatigue, insomnia, nausea, vomiting. That pain really does cause like the nausea, vomiting to go way up there, especially if they're having pain. But sometimes in women, they're just nauseous or they're just tired, which can be kind of a common thing, right? If you have like kiddos running around, maybe you shouldn't get a good night's sleep last night. So we really need to pay attention to those like non-specific symptoms. And, our women are our clients with diabetes and kind of our aging population, okay? And then as well as these other symptoms, we are going to have some EKG changes. So we'll look at an EKG strip here. So we can have a non-STEMI, meaning our ST segment elevation, ST segment is not elevated. A lot of times it can be inverted with a non-STEMI. Okay, and then we also have a STEMI, which is an ST segment elevation MI, which is a mouthful, and that's why we call it STEMI. So with a STEMI, that ST segment, right, is going to be elevated, like it says in the name, right? And then it's going to be elevated in 2 consecutive leads. So when we have 2 consecutive leads, that's looking at like one side of the heart. Okay, so when you have a 12-lead EKG, you're taking basically 12 points, like 12 points of view and like looking at the heart at one time. So we need it in 2 consecutive segments. So like we know that from this angle, the heart is injured. That's why our ST segment is elevated. We can look, our troponin is going to be elevated here, our myoglobin, our CKMB, those things. They may not be elevated if the client has only had chest pain for, 20 minutes or so, because as the heart is injured, it starts secreting those things, right? We're secreting troponin because we're injured. So it may take a while for those things to show up. And then after the MI has resolved, after we've done something about it and treated it, we may still see rising troponin levels because it takes a while for those to become circulated through the blood, right? Okay, and on this EKG here down below, you can see that ST segment, we have our QRS, our Q that's big and tall, and then that ST segment elevation that's really, really prominent. That if we see that really at any time, we need to notify the healthcare provider and start thinking STEMI is happening, okay? STEMIs are also more deadly than our non-STEMIs. They're a bigger emergency. So let's talk about what our goals of care here are. So big thing is we want to restore the blood flow. The problem is we're not getting blood flow. So let's open her back up. Let's get the blood pumping again, okay? In like the ER, an emergency setting, those kind of things, we want to give aspirin. That's an antiplatelet. So it's going to prevent worsening thrombosis. Okay, so we want to give an aspirin immediately. We also want to give like sublingual nitro. They have nitro sprays as well sometimes, but typically you'll see that sublingual. Does anybody know why we give sublingual nitro? Let's think about it. We know that nitro helps dilate. Okay, so if we have a clot, if we have a blockage, if we make the pipe bigger, blood can go around it a little bit easier, right? It's going to like increase that O2 supply to the heart, right? Because the blood can flow around the blockage. That's really important. And then it just kind of helps relieve symptoms. This is going to be a temporary fix, right? Because that medication is going to wear off and we're going to be back to where we started. But it is important to give it in the meantime until we get onto more serious interventions. Another medication we want to give is morphine. It vasodilates. It also lowers our myocardial O2 consumption. So that's really great. If we can get our heart to work with just a little bit less oxygen, like that would be great. In the meantime of like getting things fixed up. We can also administer oxygen, especially if our SpO2 is lower than like 94, 95, kind of depending on policy. And then, or if our client's really short of breath, right? Our oxygen is not getting through, we can give them a little boost that way. With these clients in the ER, we want to make sure we're monitoring an EKG. We want to get that 12 lead, but also just have them on continuous telemetry, get vitals really frequently, those kind of things. And then prepare these clients to go to the cath lab. That is going to be like the big thing here. We need to prepare them for PCI, which is percutaneous coronary intervention, getting a heart cath and a heart stent put in, okay? So balloon angioplasty is something that we want to do for these clients. They go into the cath lab. They can go through their radial artery or through their femoral artery, go up, take a peek around in the heart, see what's going on, right? If they see a blockage that needs fixed, what we'll do is we'll feed a catheter in. We feed a deflated balloon in. We inflate that balloon very quickly. It's a very controlled process. We inflate that. And what that does is it takes all the plaque that's like sludging up our arteries and it pushes them back to the walls where it should be. Okay. So now we've created an opening. So that's something we want to do. Additionally, we want to put a stent in that place. Let's hold everything in place. Let's make sure we're keeping that open. So a stent, I always think of it as like those finger traps that you used to play with as kids where you could like stick your fingers on each side, that kind of like tube that has like kind of a grid pattern. It's flexible. A stent is like a little tiny, much more advanced version of that. Okay. So we put the stent in. That keeps the artery that we just fixed. We're keeping that open. Okay. Blood can flow through. Now we can take our catheter out, send these patients up typically to the ICU. Okay. If they've had a STEMI. At that point, we want to monitor several things. So we've just been poking around in an artery. We're at risk for bleeding, right? Especially when we poke around in an artery versus a vein. Arteries have that pressure behind them, right? So especially if we're like hypertensive because we've been in pain, we're at high risk for bleeding. We've also likely given them some anticoagulants. We're at high risk for bleeding. So we want to make sure that we are monitoring for pulses distal to whatever that cath site is. So if we have a cath going through the radial, we want to monitor pulses here. And then through the femoral, we want to monitor like our pedal pulses, those kind of things. We also want to monitor for any changes. Obviously, any like bleeding at the site means we're bleeding, right? But if they go through the femoral artery, we can have internal bleeding that maybe we don't see as easily on the outside. So if they complain of like really severe back pain, those kind of things, that's a red flag, a sign we're bleeding. I would definitely jot that down on my UWorld flashcard because that's kind of a big one. They're just really high risk after this procedure. We're also going to monitor these clients on telemetry because the heart has over time become used to less blood flow, right? We've had this plaque building up slowly until finally, the blood flow is cut off. We have now just reopened it. We are letting all the blood in. So our heart sometimes can be like, whoa, what's going on? We're at risk for arrhythmias here, okay? We can sometimes have like PVCs, some like reperfusion beats, those kind of things. We're just at really high risk there. Additionally, after a PCI and a stent placement, we want to make sure these clients are getting some form of like long-term anticoagulation. So something like clopidogrel, I can't think of it. Ticagrelor. Ticagrelor. This is why you need to know your generics. So we want to give those. And the big teaching point with these clients is that they need to stay on these medications long term, okay? Never just to discontinue them. And a lot of times these medicines are really expensive. So that can be a problem. And that's something like as a nurse, we can kind of start that conversation of like, can you afford these medicines? Do we have coupons available? We want to make sure we're getting like other support people on board, our case managers and whatnot, just to make sure that these clients can afford their medication. Because when we put that stent in, it's a foreign body, right? Our body doesn't like it. So what we're going to do is we're going to try and fix it, and we're going to send some more platelets and everything back to that, and then we'll end up with another clot, and then we'll end up with another heart attack, right? So we want to prevent the clot from forming like in that stent. We want to keep everything open. So they need to be on these anticoagulants. Some other medications that we definitely want to be on after an MI like this or a STEMI, beta blockers, something like metoprolol works really well. Obviously, if they're hypotensive, after a PCI or something like that, we may want to hold or talk to the doctor. But beta blockers are really great. They help reduce our heart rate. They reduce our blood pressure. They reduce our contractility. We need them to prevent reinfarction. And this is a lifelong drug that these people are going to be on. Another one is an ACE inhibitor. Something like lisinopril works really well. That helps prevent ventricular remodeling, which is really important to reduce the risk for heart failure, okay? After MI, all that stress on the heart, we are at risk for heart failure. Another thing is a statin. Anybody with coronary artery disease to begin with should be on a statin, but especially if we've had an MI, we're going to need to be on that for life. And those are usually pretty inexpensive, so that's kind of an easy one. So yeah, that's kind of like PCI in a nutshell. I know that's kind of a lot of information to take in. And if sometimes they get in there and they say, hey, we're not a candidate based on where the blockage is or the quantity of blockages, maybe we're not a candidate for stents and we need to go for something like a CABG, which is a coronary artery bypass grafting procedure. So basically what we're doing is we have our blockage here, right? We are going to reroute instead of going straight through. We can't because we're blocked. We're going to go from the top around to the bottom. So think about like if there is an accident on the highway and everybody starts exiting on the access road and then they come back on to go around that block. Like that's kind of what a CABG is, right? We're just kind of going around the blockage because we aren't able to fix it. That's going to involve way more detailed interventions. We're going to be in like a cardiac ICU, those kind of things. So we're not going to get into all that today, but just know that is an option for clients where stenting isn't capable or isn't able to be done. So let's talk about nursing interventions. We've talked a lot about monitoring, EKGs, medications, those kind of things. Any nursing intervention I would jot down in your UWorld notebook. Those are really, really great things to make test questions out of, right? What are their nurses supposed to be doing, right? That's what we need to know. So when these clients come into the ER, we want to keep them on bed rest, limited activity. We want to do things that decrease the oxygen demand of the heart, right? We don't want them up and running around. Additionally, after PCI, we want to keep them on bed rest, especially if they've gone through the femoral artery. We want to keep those clients flat. Any bending at the waist increases that pressure, increases the risk for bleeding. So we want to do that. Before a PCI, we can put them in like a semi-Fowler position, something like that, just to kind of help, use gravity to our advantage and help our breathing a little bit. We want to monitor for different heart tones, for murmurs. We want to make sure afterwards we are assessing their lungs really well, right? So we talked about MI increasing the risk for heart failure. Heart failure, we can have some backup of fluid into the lungs. So we need to be paying really close attention to that. And if we notice that, we need to report that to the healthcare provider. Additionally, sometimes we can, monitor enzymes afterwards. For sure, we want to monitor before we do any intervention, but that's another great thing to watch for. And then we also want to teach these clients about like lifestyle changes, right? So what got us here in the first place? Is it that we were smoking? Is it that we eat fast food every day? Is it that we work in a really incredibly stressful job? We want to look at those things and set realistic goals with our clients, right? We don't expect these people to start running a marathon like next week. It's not realistic and it wouldn't be good for the heart. So we want to set realistic goals. So things like increasing your activity from 0 minutes to 15 minutes a day, or doing light things around the house, like maybe taking the stairs instead of the elevator, those kind of things. And we really need to make sure that we're having them follow up outpatient with their healthcare provider, because we may not be ready for that yet, especially if we've had some like really bad complications. We may need cardiac rehab and those kind of things. These clients also need a lot of education about medication, right? Like, why are we taking this? What do we need to monitor for? So that's kind of where nursing comes in. We do a lot of that, right? So we definitely need to be teaching them why these things matter. I have found personally, like just with my experience, that if we don't teach them why they need to take these medicines, we're probably not going to take these medicines as much. So that's why it's really important to teach them like why we need some anticoagulation after the stent goes in. It's so you don't have another heart attack, right? That is additionally really important. So yeah, I think that like covers most of it in a nutshell. Some other complications we, kind of talked about here and there, but like dysrhythmias are a big one, cardiogenic shock, pericarditis, ventricular rupture, right? Especially if like that ventricular muscle has started to die. Now we have everything working again. It's too much pressure. We can have rupture there, and those kind of things. So let's go back to our question here and look at it again. Now that we've kind of gone through all of this, let's see if we can answer this question. Okay, so our question again says the nurse has attended a staff education program about myocardial infarction or MI, which we just talked all about. Which of the following statements by the nurse would indicate a correct understanding of the program? Select all that apply. So as a reminder, we're going to have multiple correct options here, and we are looking for our true statements to be our correct answers. Okay, so option 1 says MI is diagnosed with a nuclear stress test. This is an incorrect option. Hopefully you caught why when we were talking about stress tests earlier. So stress tests do not diagnose an MI. Stress tests can help determine our risk for MI and be kind of a diagnostic tool for coronary artery disease, right? But they're not going to help us diagnose the actual MI. At that point, if we're having an MI, a stress test is not the thing we want to be doing, because that would really increase the oxygen demand on the heart. Option 2 says nausea and vomiting may be symptoms of MI. So this is a correct answer, right? It's a true statement. We know that nausea and vomiting can happen because of the pain associated with MI that can kind of stimulate that nauseous response. Additionally, in our women, remember our diabetes, clients with diabetes, and then our older aging population, nausea and vomiting can also be a nonspecific symptom. Okay. So that's a correct answer. And then option 3 says aspirin should be administered to clients experiencing MI. That is a correct answer. It's a true statement. We want to give that aspirin. Drop in the chat if you remember why we're supposed to give aspirin. And then option 4, it says diabetes mellitus increases a client's risk for ST segment elevation MI. This is a true statement. Diabetes increases our risk for MI all around, and STEMI as well. A lot of times diabetes can contribute to like hyperlipidemia and those kind of things. And sometimes other lifestyle factors that contribute to diabetes also contribute to coronary artery disease and MI. So we just want to really educate these clients about that. Additionally, we talked about the fact that our clients with diabetes will have those non-specific symptoms. So we really need to kind of take control and prevent an MI from happening in the first place. So that's a correct answer. And then option 5 says MI is caused by altered impaired electrical impulses from the SA node. Now, after talking about this, we know that MI is caused from a blockage in the coronary artery. It really didn't have anything to do with the SA node, although we can start to have dysrhythmias, after, just because of the injury to the heart muscle itself. So let's see, 2, 3, and 4 were our correct answers for today. Hopefully that really helped you guys. I know that was kind of a lot of information. Feel free to watch this back, share it with somebody else you're in nursing school with that may need like just a quick refresher on MI. Rewatch as many times as you need. That's always really helpful. But thanks so much for tuning in today. I think we're going to have just so much more fun, going through all these things. I just think this is a lot of fun to get on and talk about stuff. But like and follow UWorld Nursing on whatever social media channel you use, whatever your favorite is, or multiples if you want to be extra. And know that we have a free trial on UWorld.com. It is so great. There's our content is just so incredible. We talked about that earlier, that, we constantly look at it, make sure it's up to speed, up like to clinical practice. So definitely check that out, and we will see you guys next time. Bye.